Next 20 minutes we are going to review three concepts. The first one is the cerebral circulation, the cerebral blood flow, autoregulation, and cerebral perfusion pressure. Talking about the first point, cerebral blood flow, we have to say that our target organ doesn't weigh so much, 2% of the total weight of the body, but have an high oxygen consumption, 20% of the body total oxygen consumption and 25% of the glucose utilization. And for satisfy these needs, it requires 15% of the cardiac output. Looking at the number 15 and 20, explain you that the extraction of oxygen of this organ is higher compared to other organs. Which are the unique features of the cerebral circulation? The first one is that the histology of the artery is quite different between the general circulation and the cerebral circulation. As you can see, the most important point is there is only a single elastic lamina that is important because the reactivity of the vessel is important. We will talk about autoregulation in a while. There are some differences in species, and if you look at the paper, and you look at the paper in the experimental setting, are quite different compared to the human being, because more than 80% of the circulation comes from the two carotid arteries. There is a need to maintain a flow, even if one of the carotid is obstructed, and there is the polygon in Willis that help to satisfy the metabolic need when there is a stop in a conductive vessel. The venous drainage is quite different compared to the other organs because the veins doesn't go with the arteries, and more important, looking at the sinus, they are the main venous are inside the sinus, and the sinus are not compressible, so the outflow is preserved even if the ICP is high. So the important to maintaining an adequate blood flow and an outflow from this high metabolic demand organ, 15% of the cardiac output, needs a good venous drainage. Compared to the general circulation, one of the most important points is that we have a barrier, the so-called blood-brain barrier, and the capillary lacks fenestration compared to the general circulation. That means that looking at the electronic microscopy or at the histology, there are some proteins, occludin and claudin, that close the space between the endothelial cells and keep the extravascular space separate from the vascular space more closely compared to the general circulation. The reason for that is that the transport of many substances, if you look at the glucose, for example, okay, here, the glucose is actively transported. So the difference of concentration we are going to study in the next few hours, we will talk about also microdialysis, are due to active transport, not passive transport like in the general circulation. Moreover, we have astrocytes that cover about 99% of the surface of the vessel. And if you look at this image, you can imagine the vessel going inside from the PL artery, penetrating artery. They are all surrounded by astrocytes. They are not only due to a reinforcement of the blood-brain barrier, but they have also metabolic activities we will see in a while. We have direct neural influence on CBF that comes from distal brainstem or locus coeruleus loci. That means that we have a control of the local circulation, and we will see in a summary in the next slide about this concept. We have a neuronal activity we need to preserve. This is our target. And there are some coupling. We will see later on the metabolic and the pressure autoregulation, but there are some metabolic coupling we did discover in the last 15 years. There is a coupling between cerebral blood flow and neural activity. That means that before you start the movement, for example, of your hand, the flow starts to increase a little bit before you start to move your hands. And there is a coupling of so-called neurometabolic coupling. That means that glucose, when the activity goes up, starts to require more glucose, comes from the astrocyte, lactate being metabolized by the astrocyte, that is a fuel for the neuronal activity. And there is also a coupling at the level of blood-brain barrier. That means that the glucose, for example, is transported more actively if there is an activation. Having said that, we can be very broad, saying that the whole brain cerebral blood flow is 50 ml for 100 grams minute, but we have huge difference that are due to the different neuronal activity. There is the gray, have an higher metabolic demand and needs more flow. There is white matter with lower metabolic demands, with lower flow. So we have heterogeneous flow even in the normal situation. And if we look at, for example, this is data from Jonas studying the cerebral blood flow with CT scan, xenon CT scan, you see that we have area with low and high flow in the different area of the brain. But metabolism change across the different age, from childhood to elderly. So the reduction of metabolic demands have a reduction of flow across all the ages. This is the explosion of the first 12 months, and with a high metabolic demand and a high flow in the first part of the life. So talking about flow, flow is important because the metabolic demand is high, and there are many mechanisms that try to keep the flow constant and couple the needs of the brain, metabolic needs, with flow. In intensive care, we are used to talk about cerebral perfusion pressure. That is the driving force bringing the flow inside this organ. And compared to other organs where the perfusion is calculated between the difference between the arterial and the venous pressure, talking about the brain, we have to refer to some experience, dated 1968 from Ausby, that says that the outflow is dependent from this Starling resistor. That means that the flow from the cortical veins have the pressure of the CSF, cerebral spinal fluid liquid, across the vein, and the flow is dependent also on ICP. High ICP compress the vein and reduce the outflow. So the perfusion of this organ is not the difference between mean arterial pressure and the venous pressure, the superior sagittal sinus pressure, but is influenced by this Starling resistance, and the equation is CPP is equal to mean arterial pressure minus ICP. And CPP, being very broad in the concept, is the net driving force bringing blood inside the skull and to the brain. It's easy to obtain. In your monitor, you have arterial pressure, ICP, and the difference between the two is CPP. You can see it on your monitor. It's very easy. But CPP is not flow, because the flow is the relationship between the driving pressure, CPP, and the vascular resistance for the flow. So it's an indirect measure of the flow, but it's not flow, because CPP is the product between the flow and the resistance. And for being more clear, it's not a direct flow measure. We will see in a while why is, I say that, and I'll apply the concept at the bedside. Physiologically, for a huge range of pressure, huge range of CPP, but you can avoid to talk about CPP, you can talk also about mean arterial pressure, because in the human being, ICP is below 10 in normal condition. And for a huge range of pressure, phylogenetically, we want to keep the flow constant, And this is due to changes in the resistance of the vessel we will see in a while, because we want to satisfy the high metabolic need. And for high arterial pressure and for low arterial pressure, this relationship is lost because the vessels are massively dilated, and so the flow becomes pressure passive. This goes inside the autoregulation concept and say that we have different kinds of autoregulation. Today I will explore only pressure and metabolic autoregulation. And talking about the pressure autoregulation, we have to return back to physiology more than 100 years ago, to Bayliss, that described the effect of the stretching of on the artery that produce a constriction of the artery when are stretched. But if you look at this concept more clearly, more physiologically, and more actual, we can see there are some mechanical receptors inside the vessel muscle of the arterial vessel, and when the pressure inside the vessel goes up, there is initially a very short dilatation, but the reaction of the muscle is to constrict for maintaining the flow constant. This is due to an entrance of calcium and a depolarization of the smooth muscle producing contraction. Looking at the concept, in this slide, we already see this slide, there is a constant of flow for huge arterial pressure, changes in arterial pressure. That means that if a patient or if a subject experience a reduction of the pressure, like when you wake up from the bed, your pressure goes a little bit down, but your flow doesn't change, the situation is due to the fact that the vascular caliber dilates, because the need is important to maintain the flow, and this produces a reduction in the vascular resistance. If you go to what we see in a while when we talk about ICP, we are talking about volumes. The vasodilatation produces an increase of the volume inside the skull. And if you don't have any intracranial hypertension, this effect doesn't produce anything. But if you are in a pathological condition, as in this one, at the flexing point between volume and pressure, and every change in volume now produces a steep increase in pressure, this effect of reduction of the arterial pressure produces high ICP. So it's a defense mechanism because the flow needs to be constant, but could produce some effect on intracranial pressure. On the other side, if you look at the same curve and you look at the effect of rising the arterial pressure, you will see that the vessel will constrict normally in the normal subject, and the resistance goes up, and the resistance goes up. The net effect is the cerebral blood flow doesn't change. But if you look at the pressure volume curve, this increase in arterial pressure, keeping the same cerebral blood flow because the constriction of the vessel, the Bayliss effect, produce a reduction of the volume. In normal situation, as are we now, doesn't produce anything. The ICP doesn't change. This mechanism, if the ICP is high, produce, on the contrary, a reduction in the volume, and could be useful in some clinical situation. And this has been used in the past very frequently, the reduction of the volume linked to the reduction, to the increase of the arterial pressure. But the problem we have is in our patient, the autoregulation could be impaired, so means that is switched to the right or completely lost, as in this slide. So the flow could become pressure passive. Is this situation common in neurocritical care patients? Unfortunately, yes. If you look at the data from some paper, but we have many other, and you look at the period from a trauma, early, the first 48 hours, 3 or 5 days after the trauma, you can see that impaired autoregulation is quite often present and is more often disturbed in more severe patients and is absent in a certain percentage of patients. But as you can see, these changes could modify during the time when the patient is going to heal, the autoregulation return back. So you have to test this situation, and there are many ways for testing this relationship. One of these is the so-called PRX, that is a relationship, mathematical relationship between ICP and arterial blood pressure. That means if this relationship is positive, the patient is pressure passive, or if it's negative, is able to autoregulate. Could be done with a computer having the two signals, ICP and arterial pressure. In the last few minutes, we will go at metabolic autoregulation. As Mosso demonstrated in 1881, the flow changes, and it produced changes in pressure. This was a patient with a skull defect, and when he was invited to hear, as example, for sounds or thinking about to pray or something like that, the flow did change, and he recorded the flow more than 100 years ago. And the changes in flow are due to the activities, presynaptic, postsynaptic, and action potential. We need some flow for the resting situation, but most of the flow, 80% of the flow, is due to metabolic activity, changes of the flow. This has been demonstrated in the past in anesthesia and other setting where increasing cerebral metabolic demands is linked, closely linked in change with flow. But the reason of this change is the changes in the interstitium of the pH due to production of CO2, increasing potassium, and the main effector of this vasodilatation or vasoconstriction, vasodilatation due to the activation are nitric oxide, mainly nitric oxide, but the change is due to changes in pH in the interstitium. That means that when you have activities, the CO2 production in the neuron produce a change in pH that produce an immediate vasodilatation. But as I said you before, this mechanism happened a little bit earlier than the production of hydrogen ions. That means that there is a neural control on the flow. Concluding this presentation and putting things together about autoregulation, the flow needs to be constant phylogenetically and is protected the cerebral space from changing in arterial pressure, because if you have very low pressure or very high pressure, we don't want to have changes in flow. We need to keep this flow constant through a huge range of pressure. We have some metabolic activities, and an increase in metabolic activities, increasing PCO2, changes in pH, produce changes in flow. And we didn't discuss till now, but we can add that if the tension of the oxygen locally is very low, also very low PO2 produce a vasodilatation and needs for having oxygen available locally. Concluding this presentation, and I think we spent 20 minutes, we discussed about cerebral blood flow and the importance of cerebral blood flow. We discussed about CPP, an easy number you can obtain at the bedside, but doesn't mean flow. And we review, but in the next few presentations, I think we return back about autoregulation and flow metabolism coupling. We will review some concepts about autoregulation. Thank you very much for your attention.
Thank you, Giuseppe.